Hospital Readmission Project, using predictive models for better outcomes and lower cost of care. Avoidable readmissions affect patient outcomes and are costly. Readmissions within 30 days of discharge cost hospitals around $41 billion annually, and in 2/3 of cases, cost hospitals more than the original admission fees. In addition to hospital costs, if patients are readmitted to hospital within 30 days of discharge, the government also imposes significant financial penalties on hospitals. The federal government evaluated over 3,000 hospital readmission rates in 2019-20. Of these hospitals, 83% will face penalties for high avoidable readmission rates. Hospitals know that they need to better monitor patients after discharge, but it is impractical to do this for all patients. As you are all aware, the hospital maintains a comprehensive database with patient data. This data was used to apply automated machine learning and create a predictive model to identify patients that pose a higher risk of being readmitted after discharge. As a patient typically faces different specialist and medical staff, this model will be based on the entries made by all these specialists, rather than one leading physician. The model incorporated all information in the patient data, but a few points were amplified in order to improve the accuracy of the model, namely the number of inpatient visits, ICD-9 codes for diseases that correlated with readmittance, and whether the HbA1c test was conducted. The model that we have created was trained with the data from 8,000 diabetes patients, and 2,000 lines of data were reserved for further verification of the model. The accuracy of the model is reasonable. Depending on where we set the decision threshold, we can adjust the percentage of patients that are likely to be readmitted. This is important because we don't want to flag too many patients, but neither do we want to miss too many. The optimal threshold is very much related to the cost of additional care to avoid readmissions versus the cost of being financially penalised by government for avoidable readmission of patients. The original database showed a readmission of about 40% of patients. If we deploy the 0.3 threshold, as in the upper matrix, we would identify 84% of the patients that were readmitted. However, we would have taken precautions with 68% of the patients, which in turn would have led to high costs for avoiding readmission. If, on the other hand, we deploy the 0.5 threshold, as in the lower matrix, we would have identified 41% of the readmitted patients. Reducing the penalties for about 41% of readmissions, while the costs for additional measures would have been much more moderate, as we only would have taken precautions with 25% of the patients. The proposed model can easily be implemented in the hospital's current patient database. We used a product named DataRobot for our analysis, and this cloud-based software can be accessed by our patient database through the API interface. What this means is that we can add an extra field to every patient card, and in this field, DataRobot will write either a probability in percent or simply high or low. As the link will be dynamic, the patient card will be updated after every change or new entry, so that medical practitioners immediately see how the model predicts readmittance risk after every change. This is just a first step in incorporating AI into the hospital's patient database, but there are many more feature applications that can emerge from this, such as the risk of entering intensive care, staffing needs, or predicting bed occupancy. It all comes down to the accuracy and broadness of the data. The database we used had quite a few fields that were not complete. By getting better at this, and even adding several fields that are to be determined, the model is likely to become more accurate and the application areas could be widened. Hospital readmissions within 30 days are problematic for patients and costly for hospitals. Implementing an AI model into the patient database can indicate an elevated risk for readmission prior to discharge, so that measures can be taken to delay the discharge or adapt the care plan. By adjusting the decision threshold, the hospital can avoid over or under flagging. After implementation, the model can easily be improved at a later stage using the added data points and recreating the model. More complete or even additional data fields would be of great benefit.